Hello and welcome. How is everyone? Back for more? This time last year, the last year's class, they'd already had me for physio, so they kind of knew how bad it was going to get. You guys still had that thin veneer of not knowing. You only had pharmacodynamics, thought the test wasn't too bad, and now you're here. Bugs and drugs. Hit the ground running. Anyway, so welcome to Clin Pharm 1. This is going to be the rest of your life. No, I'm just kidding. So I'm going to do a quick overview, kind of talk about how the course is set up, and then we'll go from there, getting right into the lecture topics. I did get clearance from your class president that I get to go till 5, so you guys are ready? No. You can tar and feather him later. Anywho, yeah. You guys are free to go anytime you want. I'm not keeping you here, right? You're paying money to be here, so you want to get all your money's worth, right? No. So the grade for the course, something you might be concerned with, there is going to be 3 exams for this course. There's also 3 prescription assignments, very similar to what we did last semester. This time it'll be a little bit more intensive since we're going to be learning specifically about the drugs and how we're going to be using them. The average for the exams is going to be about 85%, with the rest of the 15% made up of those prescription assignments. The one thing to note with this class is that we don't want someone who say aces all the prescription assignments, which isn't that difficult as long as you follow instructions, and to have a failing grade on the exam to be able to get through, right? So we set it up to where you have to at least have a 75% average on the test in order to pass the class. I don't foresee that being a problem for any of you, but I just want to let you know up front that you do need to get that passing average on the exams, and then the prescription assignments will act as a nice little booster there to kind of boost up your grade from there. Okay, any questions on that? It'll be very similar to the pharmacodynamics test in terms of it being just multiple choice, 4 answer choices, maybe a few short essays here and there, but no, just all multiple choice, right? And again, test questions can come from any aspects that we talk about here, right? So, and you'll find that the tests aren't really cumulative, so to speak, but certainly concepts may come up. Or like, for instance, now we're going to start with antibiotics. They may come up in later sections, and so you still want to know about those things because this isn't the class where you want to just kind of learn all the drugs for a section and then dump them, because you're going to be using them for your whole career. So it's important to know at least some passing information about these drugs here. So, again, you can read the objectives on the syllabus that is posted up on Canvas now. You guys can see that, correct? Okay, so you see that. The course schedule is also up there as well. That is a tentative schedule based off the CMS blocks and how those are arranged. I kind of know you're starting like 5 different sections all at once, it seems like. And I tried to organize my course to try to follow that as best I can, but there's going to be a little bit of leeway here. You may hit something first in Pharm, or you may hit something in CMS first, but we try to schedule it out as best we can. From that standpoint there. But you can read the objectives. I guess for this first test, we're probably only going to make it up through ENT, so we probably won't hit the optho stuff until next test. But we'll make that more clear as we kind of progress along. Okay. Anyway, so you can read about these objectives here. We're going to know a lot of things about a lot of different drugs here, right? So some of the things we're going to be covering includes like your mechanisms of action, right? So how the drugs are really working in the body. We're going to talk about indications, contraindications. These are all things you want to know, and you at least want to know kind of the basics for each of these drug classes as we get into them. And you're going to find that it's easier if you try to memorize things kind of in little compartments, right? So when we get into the antibiotics, memorizing penicillins. Okay, what do penicillins do as a group, right? And then you can learn kind of the individual kind of idiosyncrasies of each of those drugs as we go forward. But if you can kind of compartmentalize a lot of this stuff together into groups, it's going to be able to help you out on the test. So if you want, some people really like to use flashcards to help them out with this class in terms of memorizing drugs and different things like that. These are kind of the main things you're going to want to consider adding on to those. Not every drug is going to cover every single one of these topics, but where it's clinically relevant, we'll bring those up, right? And if you ever had a question, say you're out there on rotations or something, and you didn't memorize one of these facts, it's okay, right? You can always look stuff up. It's good to know your resources where you can go to find this information at. And so you guys are already familiar with using lexicon because we did that last semester, right? So lexicon's going to be another good one, right? So you can go through UpToDate and find your information from there. It's going to be a good resource, at least to use while you're here. But anyway, so some disclaimers. One, this class is not the end-all of pharmacology. Now, do you think after my 4 years of pharmacy school, I know everything about every single drug that was ever made? Yes. That is a false thing. You assume far too much, right? I knew almost nothing coming out of pharm school, just like you're going to feel like you know nothing coming out of PA school. That's okay. That's super normal, right? You're not being trained to be a little mini pharmacist, right? I'm trying to teach you actionable information, things you really need to know in order to make sure you're taking care of your patients appropriately, to make sure you know how to avoid certain things when you need to, and how to use certain things when you need to. And so because of that, it's really important to know your resources, because you're not going to know everything. You want to know when to look stuff up. Now here, we're probably going to be covering on the order of hundreds of drugs, right? Does anyone know like kind of what the average is for a practitioner once they get into their specialty, how many drugs they normally use? Like 70 to 80 on the outside, right? So again, you're going to be very comfortable with a certain set of drugs. So if you go to work derm, guess what? You're going to know your derm drugs backwards and forwards. Cardio stuff comes up, guess what? You're going to be a little less familiar. You can look that stuff up, right? So it's good to know these resources and get familiar with them now. So guidelines are super important, textbooks, other references, etc. And always make friends with your local pharmacist if you need to. We respond well to flattery, gifts, things like that. Always make friends with those people because we can help you out sometimes in a pinch, right? I do that daily. You know, I think 8 out of the 10 PAs that work in the surgery department over at Nemours are former students of mine, and it's a collegial sort of atmosphere, right? They help me out, I help them out, etc. Again, this is the kind of the relationships you want to try to garner in your clinical practice. Getting down into the art versus the science. So is medicine more art or more science, do you think? Definitely more art, right? You're going to find there's a lot of shades of gray in medicine. It's very rare that you have a yes or no answer. And in fact, when you guys ask me a lot of questions, what's my answer to you usually? It depends, right? And that's a valid answer, right? But you need to have some qualifiers on that to be able to follow up on that sort of thing. So just know that you can come up and be like, well, you know, is this A or is it B? And we'll be like, well, it's kind of C, right? That's okay, right? That's part of the grades there. And so it's tough for students to kind of get that, but we want to try to incorporate different things here. And that's important when you're looking at the differences between professors, right? So if Professor Q is talking about something in ENT, he says one thing, and I say something that may be conflicting with that. Is one of us wrong, the other one right? You may have your opinions. I would say, no, we may both be right in those cases there, right? I'm usually the wrong. No, I'm kidding. So you're going to find there's conflicting opinions, there's conflicting perspectives, right? So it could be that we're both right. It just depends on the situation. So that's why it's really important when you have questions like that to bring them up. And you can say, hey, Professor Q said this or Dr. O said this. That's okay. We'll talk about it, talk about context, and try to come up somewhere in the middle where we can say, okay, well, from this perspective, this is true, but then in this case, this is also true. So again, try to keep that in mind. Try to keep your mind open for those sorts of things as those questions come up. And if something doesn't look right, always ask a question. It's much easier to ask a question early rather than make a mistake and then try to follow up on it later. They're very similar when you're studying for this class. You can spend 2-3 hours just looking at one sentence on a slide and just not get it. Is that a very good use of your time? No, it's what you need to do. Oh yeah, so you can start, put it aside for later. You can email me. You can talk to your fellow classmates who someone who may has a better idea than you about something. Totally just don't, if you get stuck on something, move on from it, follow up later. That's totally appropriate. That's totally okay. Again, I can sometimes 5 minutes in my office can save you 2 hours of studying time later on. So reach out early. I really recommend that. I'm never going to turn you away from my office. If you show up at my house, I will likely turn you away at that point. That's just creepy. Don't do that. But in my office, always open door policy there, okay? Anyway, so getting into it, section 1, this is where we're going to hit the infectious disease and miscellaneous agents that fall into that category. Why do you think we start with bugs and drugs? Comes up everywhere. It doesn't matter if you're doing ENT, doesn't matter if you're doing cardiology, pulmonology, if you're doing ortho, if you're doing anything with the body, guess what? Bugs can infect it, and we need to know how to treat those sort of things. So because this is such a pervasive sort of topic, this is why I cover this first. It's also a way to kind of blow your minds early, to kind of just dust out the cobwebs a little bit. You've been on break too long. You know, I say 2 weeks is just it's too long a time. We need to really be hitting you with as much information as possible. So I'm trying to play some catch up here. So there's a lot of drugs we're going to cover. If you have any questions, please stop and ask me. The sticky board is also there as well. If you can't access that, let me know. And ask questions there. We'll follow up on those at the break and at the end of class. Okay? Any questions to start out with? All right, you're all sufficiently scared now. Let's get into it. So let's start with a little bit of a microbiology review. You guys are taking micro. I'm not going to go into near as much depth as you're going to see with that, but at least want you to know the basics in terms of what we need to know in order to treat these infections for our patients, right? So first off, at the very bare minimum, we have our gram-positives and gram-negative bugs, right? What's the difference between the two? The cell wall is a big difference between the two, right? And that influences whether it takes up the stain or not. So for instance, here the gram-positive takes up that stain. That's why it turns that kind of nice purpley sort of color, versus if it does not take up that stain, it's because of that lipopolysaccharide on the outside of it, it has that more of a pink sort of color there. Now again, how often are you going to be looking at bacteria? from your patients? Probably never, right? But you're going to get that report back that says, hey, we found gram-positives and clusters on that patient's bronchial aspirate. You know, we found gram-negative rods in that patient's urine. You need to be able to make interpretation of that, right? Again, even if you're not seeing it, you at least know what this means when I say gram-positive versus gram-negative. So let's get to know your bugs a little bit, right? So let's get into some basics in terms of what we need to know to make sure we're choosing the right drugs for our patients here. So starting off with our gram-positive cocci specifically, we have our staphylococci. There's some notable ones here that we need to know about. Well, your coagulase positive bugs here are going to include things like Staph aureus. Who has Staph aureus on them right now? Everyone should raise their hands, right? We're colonized with this stuff constantly, right? But it's okay. Usually our skin's usually pretty good about keeping it out. But a lot of patients are going to get infections with this. And there's two main varieties you're going to run into. There's MSSA and MRSA. What's the difference between the two? Right. So methicillin resistant. So what is methicillin? Anyone know? It's actually an antibiotic we don't even use anymore. So you're like, why does it matter? Because it confers something about the resistance patterns of that bug to a certain class of drugs. In this case, what kind of class of drugs are we talking about? Probably penicillins, right? So if you have something that's MRSA, it means methicillin resistant. It means you can't use a penicillin for it because it just won't have the coverage. And we'll talk about mechanisms of resistance a little bit later on, but this is one of those big indicators here, right? One of those big distinctions you want to make. Which one do you think is scarier in terms of treatment? MRSA, right? So it says methicillin resistant. I mean, so that's bad, right? We're talking about superbugs are resistant to every drug known out there. That's not a good thing, right? So resistance is not a great thing for us, but it's important to know that distinction between the two there. So that's a big one to know. Staph epi, where do you think you find that? On the skin, or you find it on your epidermis. So again, that's another thing you're colonized with. Keep in mind though, when you're doing things like cultures from patients, that you can have a lot of skin contamination, right? So if you have someone who gets like say a venous stick, and you draw a blood sample from that patient there, if you find Staph epi growing in that, a lot of times it can be contaminations, right? So just because you find a bug somewhere doesn't necessarily mean that patient is infected with that, because some of these things are just ubiquitous. They're covered, you know, they're covering us right now, and that's just the way it is, right? Other things to know are things like strep pneumo. Where do you think that comes up? Ears, you know, sinuses, the respiratory tract. The pneumo should kind of clue you into that, right? A lot of upper respiratory tract, lower respiratory tract infections. Strep pneumo is going to be a big one, right? So again, when you think about like the big three causing a lot of ENT infections, strep pneumo is going to be one of those ones you want to think about, right? And then we also have the enterococci. Where do you think those show up? Intro, yeah, they're going to be in the GI tract, right? So again, these are important ones to know because again, they can have different coverage patterns. You're going to find that certain antibiotics will not cover certain groups of bacteria, and these are some notable exceptions. We'll talk more about those a little bit later on. Again, this is just kind of a brief introduction, right? We're going to talk more about where you actually find these bugs, more specifically in just a little bit. So some of our gram-positive anaerobes. So the last slide was our aerobes. What's the difference between aerobes and anaerobes? Whether they need oxygen or not, right? So anaerobes do not need oxygen, right? So where do you find those, you think? There's a nice site where you don't find a lot of oxygen. There's a lot of methane, CO2. Your GI tract, right? Absolutely. So you're going to find a lot of the anaerobes tend to colonize in places like the GI tract. You tend to find a lot of intra-abdominal infections tend to be with anaerobes, right? That's why we'll talk about coverage with our antibiotics, and it's important to know, do I need to cover for anaerobes or not, right? You also find anaerobes in your mouth of all places, right? So that's why when you think about dog bites or human bites, you have to think about anaerobes. This will come up again later on. So we have things like Peptococcus, Peptostreptococcus. Some of the bacilli is really kind of notable here. So things like Clostridium difficile. Is that a clinically relevant bacterial infection? Yes. Huge, right? What does it cause? C. diff. Has anyone smelled C. diff before? You'll know it before you see it. You'll smell it, certainly. That's a big deal. Why do we care about C. diff in terms of drugs?
Spores.
Okay, whether or not they treat spores could be something to consider. But what do you think causes a lot of C. diff infections? Antibiotics, right? Because again, you're going to find that our antibiotics don't know the difference between a pathogenic bacteria versus just our normal flora. When you disrupt that flora, guess what can take hold? Opportunistic bugs, and this is one of the big ones that we'll talk about. So C. difficile can be really, really nasty in terms of not only the diarrhea the patient develops there, but also the very invasive sort of infection that can develop here. You can have potentially, destruction of the GI tract in some cases. It can be very, very bad. So these are things we're going to be talking about in terms of complications of over antibiotic use, as we'll see in a little bit. All right, so there's some other ones. So again, anaerobes meaning does not require oxygen. That's going to be very important when you're talking about the antibiotic spectra that some of your drugs are going to have. We'll get more into detail on that later on in this section. Okay, so next we have the gram-negative bugs. You tend to find this to be a little bit more diverse in terms of the type of bacteria you're considering. You have the Enterobacteriaceae. You're going to find this happens a lot in especially things like UTIs, a lot of GI infections potentially. Normally when you think about the GI tract, you want to think anaerobes and gram-negatives for the most part. And so things like E. coli, things like Enterobacter, things like Proteus, etc. You certainly can find them elsewhere, but a lot of UTIs, a lot of GI infections, you can see this as well, right? In terms of anaerobes, the really big notable one here is going to be Bacteroides fragilis, and this will be important to know for coverage later on into some of those antibiotics. Now, some of these ones, some of the kind of the more nasty ones you have to worry about, things like Pseudomonas aeruginosa. Why do we care about this one? Okay, so it's one of the escape pathogens, right? What's an escape pathogen? They're always trying to get out of here, like trying to escape. No. They tend to cause pretty significant infections, and they tend to spread resistance pretty effectively, right? You're going to find that some of these gram-negative bugs are able to spread resistance to one another potentially. So you can have things like Pseudomonas starting to develop resistance patterns that they get from other bacteria because they're able to share little capsules of their DNA with one another, and they start to produce some of these new proteins and things like that. Most people don't get colonized with Pseudomonas aeruginosa. That's usually things like where if you have some sort of immunosuppression, or if you have some degree of, say, like an invasive device in the patient, like a endotracheal tube or a catheter. These are places where bugs like this can come up here. Things like Acinetobacter, Stenotrophomonas. These are things that most patients don't get infected with unless you have some other comorbidities or something else is causing you for that to pop up. But these are really big ones to worry about. If you have a patient who's got Pseudomonas, it's bad news, right? You want to make sure you treat that effectively. And because, again, they are very resistant, it's important to know what drugs we can use to treat that. Other things like Haemophilus influenza, Moxella catarrhalis, like those are another big ones for the upper respiratory tract. And then things like Neisseria also come up occasionally there, right? So again, these are just a basic overview. We'll get into more details on how the drugs actually interact with these bugs in a little bit. Okay, and then we have our atypical pathogens. So these don't really fit neatly into the gram-positive or gram-negative spectra there, but certainly we need to worry about these, especially in cases like a respiratory tract infection. So things like Legionella, Mycoplasma pneumonia, these are things that are going to come up pretty commonly there. Chlamydia also falls in this category as well. Does anyone know where Legionella got its name from? Yeah, so if you ever hear a clinical vignette and there's something about the AC unit being bad or something like that, usually it's going to be Legionella, mainly because it was a Legionnaire's convention or something that was going on, and the AC unit was harboring all these bacteria here, ended up causing a bunch of pneumonias. That's what we call Legionnaire's disease, essentially, is because of that. It's not like the French Legionnaires, it was actually the Legionnaires Club here in the U.S. They ended up getting the name for that one, so a little interesting story behind that. I'd say a lot of things are interesting. You may differ, but I'll call it interesting for now. Anyway, so the bugs you might be encountering here, what I think is more important for your purposes here, because again, when you're dealing with a patient, you're trying to come up with a diagnosis, and very frequently you want to know, based off the site of infection, what are the most likely bacteria to be showing up there, right? So again, this is a general overview. I'm not going to ask you specifically on this first test, what is meningitis, what are the most common bugs, right? I'm going to be more focusing on the drug aspects, but it's good to know what are sort of the common things that show up in these different sites of infection, because that's going to guide us in choosing what type of antibiotic we're going to be using, right? So that way, if I have someone who comes in with a UTI, I can consider using this spectrum of antibiotics versus they come in with meningitis, I might choose a different spectrum. Versus they come in with osteomyelitis, I might choose something else. And a lot of it is based off of what type of bacteria I think are probably most likely in that infection, right? So for instance, skin and soft tissue, what do you notice a lot of in terms of just broad categorizations? It's a lot of gram-positive stuff, right? Skin and soft tissue infections are a lot of gram-positive. Why do you think that is? It's growing there anyway, right? So for instance, if you end up having say a laceration or something, all that skin flora is going to end up getting into that wound, it could potentially cause infection there, right? Now a lot of people will show up at the ER and they say, oh, I got bit by a spider, right? He's ever really a spider? Yeah, usually it's MRSA, right? I talk about the MRSA spider that goes around and bites a bunch of people in the butt. I think it's big abscesses. But again, it's a lot of gram-positive stuff that grows on the skin anyway that causes a lot of these abscesses and other skin and soft tissue infections there. Bone and joint, very similar, right? You're going to notice, again, a lot of gram-positives. However, depending on where the site is, you may find gram-negatives getting in there. What if you had someone who was laid up in bed, chronically and they get a decubitus ulcer that goes down to the bone. Well, guess what? A lot of fecal material can get into that, and you can end up seeing gram-negatives pop in there as well. A lot of it can be context dependent, depending on the type of patient situation you're in, right? Meningitis can be pretty broad. Sometimes you have to consider what's the age of the patient in terms of what bacteria might be growing there. So for instance, if I have to worry about potentially a neonate having meningitis, it's going to be very different than if I had, say, someone who's 18, right? The antimicrobial spectrum might be very different based off the type of bugs that could be causing that infection. And again, we'll get into more details on these as we get into those individual organ systems. This is just an overview to start out with. So as I mentioned, the abdomen, what do you notice a lot of here? Gram-negatives and anaerobes, right? So again, just in broad categorizations, think about that. Gram-negatives, anaerobes for the GI tract. What do you think about the urinary tract? Mostly gram-negatives for the most part, right? And again, this is guiding me in choosing what kind of antibiotics I'm going to use, and it'll make more sense in just a little bit. In the mouth, you're going to see a lot of anaerobes that happen there. So when I think about someone who, say, gets bit by, say you had someone who was high on bath salts. You guys are familiar with bath salts? You guys remember that story of the cannibal guy that was trying to eat the other guy's face off, right? Let's say that kind of person ended up biting you, right? Well, and why were you in that situation in the first place is what I would ask you. But let's say it was to deal with the bite. Not only do I have to worry about the stuff that's growing in that person's mouth, like the anaerobes, what else might I have to consider? They're biting through your skin. Guess what? Now I got skin flora to contend with as well, right? So these are things we're thinking about in terms of what kind of bacteria could be present based on the site of infection, what other things could be playing a role there, right? Animal bites tend to be pretty interesting as well in terms of what I'm covering for. So dogs might be a little different than cats. Actually, last year we had to we got a call to the pharmacist and say, hey, what do you do for a gator bite? I got no clue. I can look it up though. That's what we did, and having to cover for some very strange kind of water bugs and stuff like that. But again, it can be very dependent on what the situation is. Okay, upper respiratory tract, you're going to see typically your respiratory sort of bugs, things like strep pneumo, H. influenza, Moraxella catarrhalis. Those are kind of the more common ones you're going to run into. And you notice the respiratory tract, lower respiratory tract, tend to be fairly similar here. Now you notice I delineate between community and nosocomial. What does nosocomial mean? Yeah, something they pick up from the healthcare environment, right? Not just the hospital, but it could be in the nursing home, or it could be someone who goes to dialysis frequently, right? Someone who's interfacing with the healthcare realm quite frequently. They tend to be more likely to develop things like MRSA and Pseudomonas. What do you think that is? Yeah, so again, you have all these different people coming to these healthcare environments. They're leaving their bugs behind. The other patient can then pick them up, right? A lot of these patients who are chronically ill can develop some degree of immunocompromisation to where they're more likely to be susceptible to things like MRSA and Pseudomonas. So again, you have to think about, what are the preceding events that led up to this, right? Do I have a diabetic patient who may have some degree of immunocompromisation? Do they have HIV? Are they a dialysis patient? All that may influence you in thinking, okay, what kind of bugs could be present here? Because I'll tell you, a nosocomial infection, you have to treat much more aggressively than a community-acquired lower respiratory tract infection because you're more likely to run into resistance and more of those virulent bugs like Pseudomonas, right? Now, how do we know whether or not our antibiotics are actually going to be effective against the bacteria we could be treating here? And so, has anyone ever heard of an antibiogram before? Very handy tool. Anywhere you work, you want to get your hands on a local antibiogram. If you're in a hospital, you want to get that hospital-specific antibiogram if you can. This is huge because it guides you in choosing what sort of antibiotics you're going to use depending on the type of bug you're dealing with. So as an example here, you'll notice that the bacteria are going to be listed here on the y-axis, and on the x-axis, you're going to have the different antibiotics you might be using here, right? So what do you kind of notice about this? You notice a bunch of numbers in here, and basically these numbers are the percentage of bacterial isolates that were sensitive to that antibiotic. Here on this column here, you have all of the number of isolates that I actually picked up here, and you're saying, okay, well, what is the percentage that if I use this antibiotic for this bug that's going to treat it? So looking here, okay, if I want to use ampicillin for an E. coli, I would have 65% chance that ampicillin is going to work in that E. coli. Is that very good odds for your patient? No, you'd say, I don't want to use that. Ampicillin's not going to get the job done, right? And we'll talk about ampicillin a little bit later, but let's use something that's much more likely to actually treat that, right? What if we use something like a ceftriaxone? 96% chance, it's a lot better, right? It's pretty good. I think odds are going to be in your favor in that case there. How about something like imipenem? 100% coverage. That's very good, right? Now, do I always want to go with the really big guns? You're going to see no, right? Sometimes you want to scale down your therapy and just use something a little bit more specific, right? So I like to talk about antibiotic coverage in terms of like weaponry, in terms of like warfare, because again, this is a battle against the bacteria, and so you talk about little guns, little pea shooters like penicillin. We'll talk about like the really big guns like imipenem and meropenem and things like that. But anywho, so this is really handy. So that way, you know, if you have a patient comes in with a UTI and you're suspecting E. coli might be present, this will guide you in choosing which kind of antibiotic you want to use. Now, this is from somewhere in Maine, it looks like, as long as I have my state's abbreviations correct. I'll say Maine for now. It's Massachusetts. You can see that as you get more advanced in your training, you end up losing some of the basics. So basics, geography and social studies, out the window, right? So this was from Mars, let's just say. All right, so Massachusetts. So let's say you have this here. Now, what if you were to say move to Florida? Do you think that'd be any different? Absolutely, right? You'd find different resistance patterns depending on where you're working at. So as an example, if you went to somewhere like high up in the mountains, where it's a much more rural community, where there's not a lot of people, you tend to find much better resistance patterns because there's just not a lot of competition there. The bacteria don't get treated with a ton of antibiotics. Versus if you went somewhere much more, say, urban, you go in the middle of the city where people are constantly coming in, getting treated with antibiotics, you tend to find much more different resistance patterns there. And so these are important things to consider. Also, think about the number of isolates you have here. So imagine here, can you really make a good determination with just an N of 2? No, we'll talk about this in EpiBio. It's coming up later on this week. If you think this stuff is fun, just wait till Thursday. We're rolling in the floors. It's going to be so much fun, right? We'll talk about N's and different things like that. But anyway, so Antibiograms super useful in terms of deciding how you're going to be treating your patients there. Because you may find that, say, for instance, I'm doing something like a Staph aureus, like an MRSA. Notice here, no coverage for a lot of these here. But I can use something like, let's say, linezolid. That's kind of too big of a drug. I don't want to use that. But something like vancomycin. I want to know how much of the drug is vancomycin resistant versus if I want to use something like, where's clindamycin? Like clindamycin here. If I notice that this patient here, yeah, 58% sensitive to clindamycin, I'm not going to use that drug for that MRSA. Right? I'm going to go with something else. And again, that may be dependent on where you work. I'll tell you, actually, when we first opened up Nemours, we just started a new hospital. We didn't actually have any isolates to draw from. So what do you think we did? Yeah, we actually went to a neighboring hospital. We said, hey, APH, Arnold Palmer Children's Hospital, can we borrow your antibiogram just to at least have an idea of what we're dealing with? And then after a while, we were able to get enough isolates that we can actually form our own antibiogram. So again, a lot of it is very region dependent. Anywho, how do we figure out if a bug is resistant to an antibiotic or not? We see if it grows in the presence of that drug, right? So here's a couple different ways we can do this. This one's called a disc diffusion test, and this is another one looking for the MIC based off of different concentrations of that drug. When I say MIC, anyone know what that means? It means minimum inhibitory concentration, right? That's the minimum concentration you need to achieve with that antibiotic in order to suppress further replication of that bacteria. It's a very important term to understand. Generally, you want to be above your MIC in order to make sure that you can help to prevent that bacteria from replicating, okay? Now again, when I give an antibiotic to a patient, is that the only thing that's killing off the bacteria? Now remember, we have our own host immune system, right? We're just trying to help our immune system beat off that bacteria, right? So we're helping to supplement that. So as long as we're above that MIC in a lot of cases, by preventing that spread of the bacteria, you're allowing your own body to come in and kind of take care of the rest of it, as the cases may be. Now looking at this disc diffusion test, and again, I'm no clinical lab person by any stretch of the imagination, but at least the basics of it are, by taking different drugs and placing it into a culture of the bacteria, you can see basically how big of a circle of inhibition that you have, right? So for instance, this right here, do you think it'd be a pretty good antibiotic to use for that bacteria? Looks pretty good. There's not really any bacteria growing anywhere near that versus something like this. It's kind of surrounded by the bacteria. It's probably not that very good at it. So you may say something like this drug would be resistant to that bacteria versus this drug would be susceptible, okay? So those are kind of terms we use pretty frequently. Susceptible means it will treat that bacteria. Intermediate means it's kind of maybe if you get the right concentrations. And then resistant means it's not going to stop that bacteria whatsoever, okay? And so this one is another case where you're using varying concentrations of an individual drug. So the higher concentrations being on this end of the stick versus lower concentration being here. And you can determine specifically what that MIC is by looking at, okay, where's the actual area where the bacteria stop growing? Okay. Obviously, the higher the concentrations, the bigger the area of inhibition you're going to be getting there. Okay. So again, you don't see this specifically. You don't get like the lab doesn't come up, bring you an agar plate and say, hey, look at this. But you're going to get those reports back. It'll say resistant, intermediate, what's the MIC. You're going to need to be able to interpret that to know what to do with the antibiotics. Okay. So we mentioned resistance is becoming a huge problem, right? How do we control that? What do we do to help prevent antibiotic resistance? Is this how you should choose your antibiotic to use in duration of therapy? Just say, I don't know, whatever works, whatever hits the wall. No, you want to be much more specific on how you do that. You want to make sure you're guiding your patients appropriately based off of things like clinical practice guidelines, based on local sensitivities and resistances and all these sorts of things here. Because we know there's a lot of superbugs that are out there growing out, things like MRSA, right? It's methicillin-resistant Staph aureus. You know what VRE is? Vancomycin-resistant Enterococci, right? VRSA. That's why I use to buy stuff at the grocery store. That's Versa, not Visa, sorry. It's vancomycin-resistant Staph aureus. It's even worse than methicillin-resistant, right? So it's even more resistant to even our bigger guns there. And so again, these are the gram-positive ones you run into more commonly, right? A lot of gram-negatives are even worse here. We have things that produce extended spectrum beta-lactamases. We're going to learn that beta-lactamases are really important in terms of the mechanism of action for a lot of our antibiotics. Well, if we have a beta-lactamase, that's going to be able to come and destroy that drug, essentially. We have bacteria that can basically do that. And the more they produce these, the less effective our drugs are going to be. So things like Klebsiella producing carbapentamases, which would destroy a certain class of drug. And then you're going to find that the majority of the resistance you run into is due to things like Klebsiella, E. coli, Pseudomonas, and then Acinetobacter. Those are the four most common gram-negative rods that you're going to find producing a lot of this resistance. Okay, so what actually causes the resistance? Well, a lot of it is not following guidelines, right? So if it says, hey, you should really be using amoxicillin for this infection, but you decide to go use something else, that can lead to resistance. Double covering, what do you think that means? Yeah, using two drugs when just one drug is going to do. Very rarely do you need to double cover. We'll talk about those individual circumstances when it comes up, but rarely do you need to double cover unless it is a very specific case, right? Not de-escalating or streamlining therapy, what do you think that means? Not just stopping the drug, but by tailoring it down to something that's much more specific for that bacteria. So we're going to talk about the spectrum of activity for these antibiotics. You have things that have very wide spectrum that cover kind of everything, or you can have things that are very narrow spectrum and only cover a few things. Usually when you start out, we'll talk about empiric therapy. What does empiric therapy mean? Yeah, kind of like, well, we don't know what it is. We think it might be this, so let's kind of go with our best hunch and treat with this. You generally go broad initially, kind of cast a wide net to try to capture those bacteria, and then you scale down, right? As soon as you get those culture results back, then you can make a more informed decision and say, okay, well, I shouldn't use this because it's way too broad spectrum. Let me narrow it down to this. That should be a common process when you get cultures back, but a lot of people may not do that for varying reasons. And that's another reason why resistance happens. Prolonged antimicrobial therapy, so treating for 21 days when 14 might do, or 14 when 10 might do, etc. And then when I think greater than 7 days on mechanical ventilation, what do you think it's more likely to see resistant bugs there? I'll tell you, anytime you have foreign material in the body, whether it's an intratracheal tube, whether it's a catheter, whether it's a urinary catheter, intravenous catheter, anything like that, any foreign material, guess what? Bacteria like to grow in that, right? And so that can introduce all kinds of resistant bugs potentially. In order to treat those bacteria, you got to give them antibiotics. And guess what that garners more of? More resistance. And you got to use more antibiotics, right? So you can see it's kind of the sick cycle. So the longer they're on something like mechanical ventilation, where you have this big tube down your throat, all the bacteria can just kind of crawl right down to the respiratory tract. The more antibiotics you have to use, the more resistance you develop. So that's kind of the big problems there. Prolonged hospital stays, kind of for the same reason. I frequently tell people the hospital is the worst place to get healthy because there's all kinds of bugs growing around there. You're more likely to have drug errors. You're more likely to have all kinds of problems. And then prior antibiotic use. Why do you think this matters? Selective pressure, right? If you apply more antibiotics, you're selecting out for the more resistant bacteria. They'll then continue to grow and then be useless, or those antibiotics will then be useless on those bacteria there. So using prophylactic antibiotics when it's not necessary, right? Prophylactic antibiotics means what? Before they develop the infection, right? So for instance, certain types of things you don't need to prophylax for. You can just use, so I use animal bites as a common one. So for instance, if I have someone who has a snake bite, I don't have to prophylax with antibiotics for that. As long as I have good wound management and good wound care and I clean that off with some soap, guess what? It doesn't get infected normally. But if I have someone who wants to prophylax against that and give them antibiotics, even though there's no infection, then it only breeds resistance. It doesn't do me any good, right? And then using too broad a spectrum of antibiotics, using things like cefepime, meropenem, we'll talk more about these in detail, but these are really broad spectrum drugs. If you don't need them, pare it down. Use something that's much more specific for what your intended purpose is, okay? Not only that, there's a lot of animals that receive antibiotics, and this actually directly affects us as well in getting more resistant bugs there. So again, another thing to note, again, if you need another reason to go vegan, this might be one of them. It's not enough for me. I still consume a lot of animal flesh, but that is what it is. So how do these bacteria actually become resistant. There's a lot of different mechanisms, and I'm not going to get super in-depth on this, but just know there's different ways for this to occur. It could be ways where the antibiotic doesn't actually make it into the bacteria itself, right? By changing the proteins here, changing porins where the drug can't even get in. It could be one way, right? Doing things where maybe you're bypassing certain metabolic targets to where the drug can't work its mechanism anymore, because the cell found a way to get around it, right? There's a lot of things that the cells can do because they replicate quickly. They can mutate their DNA very quickly. They're able to overcome these drugs with resistance, over time. And so that's something we want to be at least cognizant of. We'll talk more about these targets when we get into the specific mechanism of the drugs. Just know there's a lot of ways for bacteria to get around these drugs. Okay, and some other things we can do to try to control that resistance are going to be things like the escalation of therapy. Sometimes we'll actually do formulary restriction or antibiotic cycling. Anyone know what that means? Yeah, changing the antibiotics we would routinely use, right? So if I have someone who's coming in and I'm worried about a healthcare-acquired pneumonia, instead of using, say, gentamicin for every single patient, I'll switch it out, say, after 6 months or a year, to using tobramycin, right? A drug that's in the same class, but maybe we'll release some of that selective pressure, right? So there's different things we can do over time. We'll get more into these as we get into specific examples, but just know these are things we do, especially in the hospital setting, to try to help prevent these resistant bugs from popping up here. All right, let's continue on. Any questions so far based off of what we have already covered? I noticed the sticky board was bare. You guys must all be microbiology experts, at least at the very bare minimum that we're covering it for this case here. But let's get into the new information. Let's talk about the actual antibiotics we're going to be using here, right? So how do we choose our regimen, right? What kind of factors are we looking at in terms of what antibiotic I choose to treat what patient for what infection, right? So spectrum of activity, we already mentioned that. What do you think that is? So for a given drug, what bacteria does it cover, right? So that's the spectrum of activity. I mentioned there's broad spectrum, there's narrow spectrum. We'll cover that when we get into the individual drugs themselves. Next up are the pharmacokinetics. Has everyone already dumped all that information from last semester? No, everyone retained every little iota of that. Fortunately, you have an entire YouTube channel. You can go back and watch a year's worth of pharmacokinetics talks. They don't change that much from year to year, as it turns out. But it's important to know things like absorption, the distribution, right? So, especially when you think about distribution, because remember, we need the antibiotics to get to where the infection is, right? So if I have a patient with pneumonia and I'm giving them intravenous antibiotics, I need that drug to distribute to the lungs. Or if I have a patient with meningitis, I need that to distribute across the blood-brain barrier. That can be exceedingly difficult depending on the drug that we're dealing with, right? Certain drugs do this better than others, and that is a factor of its distribution. Remember what kind of has an effect on distribution of a drug? So hydrophilicity, but conversely, the lipophilicity of it, right, usually increases distribution, right? Things like protein binding, all these different factors are going to be big considerations when we're dosing these drugs here. And then elimination is very, very important. You've got to look at elimination of these drugs. A lot of them are renally excreted, which means if you don't have good renal function, you're going to hold on to these drugs, and guess what happens? You're going to get side effects. You're going to get toxicity from these. And some of these drugs can be pretty nasty when the levels go up. Now, when we talk about selectivity, these antibiotics are pretty selective for bacteria, but they're not 100% selective. They can still affect us quite significantly, as we'll see. Next up on the pharmacodynamics, so actually what is a drug doing itself to the body? We're going to look at things like if a drug is bactericidal or bacteriostatic. What do you think that means? Does it kill the actual bacteria specifically, or does it just kind of prevent it from replicating? And based on the mechanism, that's going to make a little bit of intuitive sense as we get into it, right? Based on the mechanism, if it's doing something like ripping open the cell wall, what do you think it does? It's probably going to kill that cell, right? If I ripped open your cell walls, you would probably die as well, right? Versus if I maybe I wouldn't do that to you, like you guys too much. So I don't get a paycheck if you guys aren't here, so it's also a competing factor. But think about things like, if I just maybe prevent protein reproduction. It's not going to directly kill the cell, but it prevents it from replicating, right? So those are things to consider there. We'll talk about time-dependent killing versus concentration-dependent killing when we're looking at things like AUC curves and whatnot. We'll look at that in just a little bit. And then the other big thing to consider is the toxicities, right? So for instance, if I have a patient who already has renal dysfunction, I may not want to give them a drug that can cause further renal dysfunction, right? If I have a patient who has hematologic toxicities already, maybe they're anemic to begin with, maybe I don't want to give them a drug that can worsen that. So we're going to look at specific instances of drugs you may want to use or maybe avoid depending on what kind of side effects they cause. So getting into bactericidal versus static, we mentioned that bactericidal will kill the bacteria versus bacteriostatic, will just prevent them from further replicating. So what kind of patients do you think I'd want to use bactericidal, say, versus bacteriostatic? So healthier patients should receive which one do you think? Bacteriostatic. Why?
Because they're biogood themselves.
Right, they can help fight the bacteria themselves. They got a good, healthy immune system, right? So it may be okay to give a bacteriostatic antibiotic to someone who has a good, healthy immune system. What if I have someone who has HIV, right? They have maybe a suppressed immune system due to their white cells not replicating because of the virus taking over, right? Maybe I want to use something that's more bactericidal in those cases there, right? So oftentimes that can make a distinction if I want to use a drug that is going to help to augment that host immune system, or if I need something to kind of take over and be much more deadly to those bacteria there. Again, we'll get into each of these specific classes a little bit later. This is a good slide to reference back to if you're trying to remember, wait a second, were penicillins, were they bactericidal or bacteriostatic? Again, looking at the drug to organism factors here. So again, whether something's concentration dependent or time dependent. So this is an important distinction to make between these two. And this will be evident when you look at how some of these drugs are being dosed here. So just as a general caveat for all of your pharm courses, from me specifically, I'm not going to be big on asking you specific doses for drugs. Okay? You may think, oh, whew, thank goodness. But trust me, there's a million other facts I can ask you about, so don't feel too good about that. Specifically, you can look up doses, right? That's not a problem here. If I have a dose on here, it's going to be to illustrate a purpose, right? So it would be to illustrate a concept, and this is going to be one of those concepts here. When I say concentration dependent, that basically means I'm trying to shoot for the highest concentration of the antibiotic possible. And it's kind of like, kind of like a shock and awe sort of thing there, where you try to like shock the bacteria into stopping replication. And then even if the levels of the drug drop down pretty low, you're going to find that the bacteria is still taking some time before it'll start to replicate again. This is something called the post-antibiotic effect. Again, we'll cover some specific examples of this. But if you see a drug that's only given, say, every 24 hours, you're giving a really big dose at one time a day, even though those levels of the drug drop down low quickly, you can still find the bacteria are not replicating actively. Okay? And again, I'll show you some graphs that make more sense of that. On the other hand, you have time-dependent antibiotics, and these are going to be things that need to be above the MIC in order to maintain bacterial kill, right? So you need to have as much time as possible above that MIC, because the second you drop below it, guess what happens? They start to grow again, right? Because that's the minimum inhibitory concentration. If I'm below that, then they start to grow again. There's no post-antibiotic effect. And so this is where if you see a drug given every 8 hours, every 6 hours, or maybe it's given via continuous infusion, that's pretty indicative of it being a time-dependent antibiotic. So looking at the graphs here. So looking at this, this is going to be an example if I were to give a single dose of an antibiotic, kind of looking at the levels here. Now, you'll notice on these graphs that you're going to have an MIC that's available there. And again, how do I determine the MIC? I'm going to plate out that bacteria into an agar plate, and I'm going to put one of those strips down. I can see what concentration it takes to really kill off those bacteria, right? And again, this is another way to do it too. You can have the bacteria growing in some of these little cuvettes here, and you can see here, okay, well, this one's cloudy, has no drug in it, versus if I increase the concentration, at what point does it become clear, showing me that the bacteria are not replicating, right? So again, this would be the MIC, which would be kind of equated here on this graph. So again, when I'm talking about this, when I give the single dose, notice here there's going to be a peak. And for every peak, there's also a trough, which would be over here on the right side. And then you're going to notice here, here's the area under the curve. This is the total amount of time that that antibiotic is above that MIC, where presumably the bacteria is not replicating. Okay. So to compare, looking at a concentration versus a time-dependent killer here, here is an example of a time-dependent antibiotic. And the beta-lactams, which we'll see in a second, are good examples of time-dependent antibiotics. Basically, the only time that the bacteria is being inhibited is when you're above the MIC, right? So again, once you get down below this, guess what? They start growing again. It's not good for your patient. So when do you think I'd want to give another dose? Probably right before it drops below the MIC. That'd probably be a really good time to give it, so that way it stays above that MIC and it continues to kill off this bacteria. Conversely, I could just give it continuous infusion of the drug 24 hours a day and get the same effect. I'm always above the MIC. What's the downside of using a continuous infusion? It's very labor intensive. You're tying up a line. The patient may not have very many lines of IV access there. So again, it's cumbersome. We don't do that too frequently. But again, that is one strategy you could do potentially. On the other hand, for our concentration dependent killers, notice here that as soon as you want to get the highest concentration available, and the aminoglycosides are a good example of drugs that do this, you want to get a really high concentration, and then even if you drop below that MIC, you'll see the bacteria do not continue to replicate. You get basically 24 hours of coverage from that, and then by the time you get the next dose, guess what? How much drug is left here? It's gone. It's completely out of the system, which is good because that actually can help us preventing accumulation of drug. That can hopefully prevent some organ toxicity. That can be really useful, right? By having no drug in the body if possible. So only certain drugs have this, and they are considered to be concentration-dependent killers. Yes, sir.
So is it really an MIC if it's concentration dependent.
Yeah, because if you never got above that MIC, you'd never really see that bacteria being inhibited there.
It's like you just hit like activation. You just gotta get over the line and then.
You just need to really just hit them like really hard right up front with that really big concentration, that really big peak, and that's what really does it. That's really kind of gets that nice kind of just suppression effect of those bacteria, right? That's a post-antibiotic effect. So even when I drop below the MIC at this point, I'm still getting good kill there. Okay, even though the levels may not be detectable in the blood, the bacteria are still being affected by that drug even after the case. Okay, so looking at this is a handy slide to reference back to when you're comparing and contrasting your different antibiotic classes. This is going to tell you basically what their mechanism of action is. You must certainly know what the mechanism of action for antibiotic is. You should know that based on test questions at the very least, right? And this is important too clinically, because if I'm going to say use 2 antibiotics to treat 1 bacteria, do you think I want to use 2 drugs that have the same mechanism? No, you want to go for synergy there. I want to have maybe one that kills them from the cell wall perspective, and then also one that works on the protein side of things. Or maybe I want to work on DNA synthesis, or maybe I want to work on something else, maybe antimitotic, something like that, to try to make sure I'm targeting multiple mechanisms, because you get better synergy that way, okay? So reference back to this. I'm going to go through all of these and more in specific detail as we go forward. So here's another handy table here. These are going to be basically just your antibiotics that affect the cell wall. Again, this is just one mechanism we're dealing with here, right? So again, there's a lot of drugs we're going to cover. So the better you can compartmentalize them into specific categories, better buckets you can categorize them into, the better associations you're going to make in your mind, okay? All right, so starting out, let's go with the basic antibiotics. The first one we had, penicillin. Does anyone have this growing in their fridge right now? Possibly. No? You guys have very clean fridges, and I applaud you. Kidding, right? Because where does penicillin come from? From mold, right? So maybe growing in your fridge, you never know. Anyway, so beta-lactams, right? So when I say beta-lactam, what is that? It's basically this 4-part structure here. This nice little square here in the middle, that's a beta-lactam ring. Okay, so I say beta-lactam, that's what I'm referring to as the chemical structure of these drugs here. And there'll be several different ones that fall into that beta-lactam. I'll kind of show you what those look like in a little bit. Now, am I going to expect you to draw any of these out or identify structures on an exam? No, I'm not going to do that, right? But again, the nomenclature is important. You want to know, why do they call that a beta-lactam drug? Well, because it has a beta-lactam ring in it. It's a structure. That's how you identify these drugs as being within that category. Okay, so the penicillins will be the first one to come up with here. And again, basically the way this works is that the beta-lactam ring basically mimics the look to the bacteria of 2-D-alanines. Okay, remember D-alanine is an amino acid. So by looking like that to the bacteria, it's actually able to get incorporated into its cell wall. And specifically, there's something called a penicillin binding protein that is really important for causing a lot of the cross-links in the actual cell wall formation of the bacteria itself. So when the beta-lactam comes in and binds to that penicillin binding protein, and guess where we came up with a name for that? From penicillin. It's the first antibiotic we had, and we realized that's the protein to bind it to, so that's what got named penicillin binding protein, right? So anyway, so again, by interacting with and inhibiting this cross-linking enzyme, guess what happens? The cell wall becomes structurally unviable, right? So you prevent the cross-links from occur. Basically, the cell wall just starts to disintegrate because it cannot form new cross-links and it cannot regenerate that wall there. I can show you another way this looks like. You imagine the cross-links here in the different proteins of the cell wall. Basically, what you're going to have is that penicillin is going to bind to that penicillin binding protein. It's then going to cause these ruptures within the cell wall, and guess what happens? If I put a big hole into you, what would happen? Everything comes out, right? Same thing happens to the bacteria. Okay, so everything comes out, and guess what? That cell is now dead. Okay, so is bactericidal or bacteriostatic? Cytal, right? Most of your cell wall active antibiotics are going to be bactericidal. This is kind of a good thing to remember there. So again, you're going to have concentrations enough to where basically all those penicillin binding proteins are being bound up. It can still make the chains, it just can't cross-link them together. So the cell wall basically just disintegrates, you get these holes, the cell lyses, and thus no more bacterial cell. Okay. So the first one we had, and this category is what we call the natural penicillins here. The first one has just penicillin G, okay? Again, when I put drugs on to test, I will always put the generic name and then the brand name, okay? That's a little bit of a crutch to you guys, mainly because a lot of drugs in the clinical world get called by their brand names pretty commonly. So for instance, who's here worked in a hospital in some capacity before? Who's here has heard of ceftriaxone? A couple people. Who's heard of Rocephin? A lot more people raise their hands, right? Rocephin is a brand name for ceftriaxone. So in some cases, just to speak the parlance of medical terminology, like you need to know what the brand names are in some of these cases here. That's just what they're called. You still need to know the generics because what does PANTS do? Anyone know? generics only. Okay, so you got to know these by the generics. But again, I put the brain names on this so you're at least familiar with it. So all my test questions, those are going to be on there, but just be familiar that PANCE is not going to give you that benefit. Okay. So anywho, penicillin G. And I also, for these antibiotic lectures, I like to put like a little stoplight sort of metaphor here in order to guide you in choosing, okay, well, is this going to be a good against gram positives? Is it good against gram negatives, etc. Obviously, green light means go, so you can use this antibiotic for those bacteria. Yellow means maybe not, depending. It's very situational. And then the red light means not going to work, right? It's not going to be very effective. So anyway, so penicillin G was the first form of penicillin that we had here. It had good gram-positive cocci activity, right? So you get stuff like staph epi, but no staph coverage, right? So no Staphylococcus aureus is going to be used for this. So if you had a skin infection, penicillin G is not going to be good for that because it doesn't cover a lot of those very likely organisms that grow there in the skin, like Staph aureus specifically. It has a little bit of anaerobic activity, but no bacteroides, so this wouldn't be really good in the GI tract either. So you're already looking at this, you're like, man, it has pretty narrow spectrum of activity. So penicillin G is pretty narrow, but it has very specific use cases for it. So as an example here, if you had syphilis, guess what? For whatever reason, penicillin's been used to treat syphilis for decades and decades, and guess what? It still remains active, right? For whatever reason, syphilis hasn't generated a lot of resistance against it. That's still the go-to drug for that, which is a good thing, right? Gas gangrene, things like meningococcus, all retain pretty good susceptibility to penicillin, even though this has been around for decades and decades, right? Notice here it's no good activity against aerobic gram negatives. So would I use this for a UTI? Probably not. Would I use this for a gut infection? Probably not, right? So again, very specific use cases because this has a very narrow spectrum, okay? Now, one of the things to note here, if you're looking at the dosing, again, most drugs get dosed in things like milligrams. Notice this one here is in units. Let's be cognizant of that, right? So when you're dosing it appropriately. And again, how do you abbreviate units? You don't, right? You always write out units. Just write U. That's one of those abbreviations we talked about we don't like to use there. Now, looking at this, we have to give this every 4 hours. So what do you think about that? Is that time dependent, concentration dependent? Time dependent killer, right? You give it very frequently to keep it above that MIC for as long as possible. So the penicillins and basically any of the beta-lactam drugs are going to be time dependent killers. They're bactericidal and they're time dependent, okay? And again, other things you're going to be looking for, of course, you hear about people who have a penicillin allergy. This is a common thing you're going to find on a lot of charts. So you can monitor for things like signs and symptoms of anaphylaxis. What would that be? Anyone know? Of hives, wheezing, angioedema, all these things you're going to be looking out for, right? So again, someone might say, oh, I have a penicillin allergy. And you say, well, what do you say to that? What is your reaction, right? And they say, oh, I had diarrhea. Do you think it's an allergic reaction? No, right? So it's important, and we'll learn the difference between expected side effects and actually true allergies to some of these medications here. Because the problem is when someone says they're penicillin allergic, you need to dig further than that, because most of the time people say, oh, I'm a penicillin allergic, and they say, well, how do you know? They say, well, my mom told me I had it when I was a baby and I can't get it anymore. It's probably not a good use case for them eliminating an entire class of drugs for the rest of their life, right? So again, you want to do a little digging when you ever hear these allergies. So other forms, you may find that penicillin G is not very bioavailable via the oral route. You can only give it IV. So there's a few other forms that are out there you're going to find. So for instance, the penicillin V potassium or PenVK, that is the actually orally stable penicillin. Doesn't get torn up by the stomach acid, can be absorbed, and has good bioavailability orally. So if you see that, that's the version you're going to see orally. There's actually one called penicillin G, but this is called a benzyl penicillin. This one is given IV occasionally. And then this one is a very good one. We use this in pediatrics a lot. It's called benzathine penicillin G. What do you notice about the solution here? It's white. A lot of IV solutions, you know what color they are? Actually clear, right? So something white like that, what do you think of? What does it look like? Like milk or something like that. So this is a very kind of viscous, very lipophilic sort of substance here. This is not something you want to give IV. Anytime you give things that are not water soluble IV, can cause embolus, right? So you want to be careful with that. This is actually an IM formulation. It's a long-acting penicillin I can just inject into the muscle, and that way it will slowly leach out penicillin into the body over a long period of time. And what's actually nice is that, say, for instance, I had someone who came up with strep, lost my train of thought there a second. They have strep pharyngitis, right? They come up, they have group A beta hemolytic strep, and I want to treat them for it. If they can't take anything orally, like amoxicillin, I can actually give them one-time shot of bicillin, LA. Anyone know what LA stands for? Long Island. It's not Los Angeles, right? geography, at least good enough for that, but it's long acting. So it's an IM formulation, you can inject in the muscle, and again, it lasts that long time, one-time dose to that patient there, right? So it's good for patients who may not be able to take things orally, or for instance, they may not be compliant, right? So again, that can be a benefit there. Okay, so you have your natural penicillins, just basic penicillin, and then you move up to the aminopenicillins, okay? Two main ones that fit into this category. You have ampicillin, and then you have amoxicillin. Now, I'm not going to quiz you specifically, is this one available IV versus PO? Again, if I mentioned specific use cases like bicillin, that one I mentioned is intramuscular only. That's kind of a good, unique sort of thing to know. But again, I mentioned this so you at least get some familiarity with how we're administering these drugs here. Amoxicillin, very common PO medication we're going to give. We're going to see that by adding this amino group onto the penicillins, we get better activity for it. So you're going to notice here that it has still no staph coverage, right? So I can't use it for Staph aureus, but it has a little bit better activity against gram-positive cocci. Again, still okay anaerobic activity, nothing for Bacteroides fragilis, but now we start to get a little more gram-negative activity, okay? Which is kind of a good thing, right? So a little bit of gram-negative anaerobes. And we use this very frequently, so we can use it for things like Enterococcus, we use this for things like Listeria. We can use it for upper respiratory tract infections. In fact, this is probably the most common antibiotic we use in the peds ER, because again, kids come up with the sniffles, they have strep pharyngitis, they have acute otitis media, they have pneumonia. This is a great one to give for them because it covers most of that stuff we're talking about, like strep pneumo, H. influenza, Marksella catarrhalis. It covers that stuff very well, and there's very little resistance for the most part, right? So anyway, so again, we're going to see that. Again, when I say CAP, anyone know what that means? Community-acquired pneumonias, right? So that means that they were just out in the community and they got pneumonia versus being, like, say, in the healthcare setting. Now, community-acquired pneumonias typically are less likely to have resistant bugs, and so I can get away with something more narrow spectrum like amoxicillin. That's okay, right? It's going to have good enough coverage for us. But notice places like the lungs are very hard to penetrate with antibiotics. So you may have to use higher doses in order to overcome that. Make sure you get good penetration of that drug into the site of infection. So that's one thing you want to keep in the back of your mind there. Is it places like the blood-brain barrier is tough to get across. Places like the lungs are tough to get across as well. Okay. And again, these are still bactericidal. They're still going to be time-dependent killers. Again, they're all fit within that same category of class. It's just that the coverage has changed a little bit by changing that chemical structure. So ampicillin and amoxicillin are the two big ones in this group. Okay. Now note, this is kind of a broad categorization for the penicillins here, but sometimes they can lead to increased bleeding time. In some cases here, it's a minor effect, so I don't expect every patient I give amoxicillin to just start bleeding out, but it can be a concern if they're on other blood thinners, right? So if they're on something like a Coumadin or a warfarin, that may be something I want to be considerate of. Now, one caveat you may hear about is anytime you're taking oral contraceptives, that you want to make sure you use backup prophylaxis if you ever take antibiotics. Has anyone ever heard that before? Okay, what do you think that is? Anyone know? It doesn't make a lot of intuitive sense when you think about it. Like, what do antibiotics have to do with birth control? It may seem like nothing at first, but the theory behind it is that one of the things that happens with estrogen is it actually gets eliminated from the liver into the biliary tract. Okay, from the biliary tract, it gets spit out into the GI tract. Okay. What's interesting is that estrogen actually undergoes what we call enterohepatic recirculation. So enterohepatic recirculation basically means when it gets spit out through the biliary tract, guess where it gets reabsorbed at? Back through the GI tract, and guess what happens to the half-life of that drug when it undergoes this recycling? It's a lot longer, right? Because it's getting recycled, so you don't lose all that drug in the feces. It just stays in the body for longer because it gets recycled, which is great. The problem, though, is that you need bacteria to actually chomp on that estrogen, because it's usually bound to something else, in order to liberate it so that it can be reabsorbed again. You need that normal gut flora in order to make sure that estrogen gets reabsorbed. So what happens if I give an antibiotic? The gut flora gets disrupted, right? I start to kill off those bacteria because antibiotics don't know the difference between a normal, healthy bacteria just kind of minding its own business versus something that's more pathogenic. So because of that, the theory is that by disrupting the normal gut flora, that you end up having less of the estrogen being reabsorbed. You have shortened the half-life of that drug, and then what happens to the female patient? You may start to ovulate, and then what happens when you ovulate, potentially? You can get pregnant, right? So that is the concern, right? So that's why they mentioned using backup methods of prophylaxis to make sure if you're ever on antibiotics, in that case there. Now, do you think there's like a really good study where we compared a bunch of women on oral contraceptives, and we gave them both antibiotics and said, okay, you get to use backup and you don't. Let's see, how many of you get pregnant? Would any of you want to volunteer for that study? Even the guys can say, I do not want to volunteer for that study, right? Because I can tell you that's going to be a long-term commitment you're going to have to be dealing with. 18 years at least, right? So, There's no studies that actually show this is a true concern. It's more of a theoretical concern. But sometimes you have to look at the risk versus the benefits, right? So again, the risk may be very small that the patient could become pregnant there. But again, what's the downside of using some backup prophylaxis for that 7 to 10 days? Probably pretty minimal, right? So again, it's always something the conversation would have with your patients. Again, they may not even be on oral contraceptives for birth control purposes, right? But have that conversation, find out, and you can make a better decision at that point, okay? Does that make sense about the mechanism behind the enterohepatic recycling? This will come up again when we talk about like anti-seizure drugs and things like that. They undergo that as well. That's another concept we'll talk about later. Okay, other side effects you can find, these tend to be, in some cases you may have some liver toxicity that can happen here, so you may see in rare cases things like jaundice, hepatitis that can develop. This is usually in patients who have kind of poor liver function to begin with, so it's going to be a rare for most patients there. There's a risk for things like Clostridium difficile infection. Where does that occur? Again, you're disrupting the GI flora. This is not going to be the most common group of antibiotics that will cause this, but really anything that can affect some of those gut bacteria are going to be possibly affected, and so this is certainly where you can see risk for C. diff infection pop up here. Okay. Has anyone ever heard of Stevens-Johnson syndrome or toxic epidermal necrolysis? Doesn't sound good, right? Toxic epidermal necrolysis. Now, besides that being my metal band's name in high school, it's actually a very severe skin reaction that you can see for some medications there. This is rare for it to occur, but it's something you at least want to keep in the back of your mind and let patients know, hey, if you're taking a medication, you ever start to see things like blisters start to pop up, you start to get sores in your mouth, anything like that, could be a sign of the skin manifestation happening here and can be deadly if not treated early. Basically, the skin just starts to slough off in huge sheets. The patient can be very much at risk for infection. It's no good. So one of those things where you want to say, hey, if you ever notice this, stop taking the drug altogether, come into the ER, and with aggressive kind of supportive care, they can usually increase the survivability of that. But if left untreated, it's no good. Now, again, this is not the drug that's most likely to cause it, but it's something you want to keep in your mind that it can happen. Okay, it can lead to some renal dysfunction as well. You can see things like crystalluria, hematuria, again, fairly rare, and then some blood dyscrasias can happen here. Again, these are things you at least want to keep in the back of your mind. You don't think they're going to happen routinely, but just want to be aware of it, okay? Now, contraindications. Patients are allergic to penicillin and they have a true allergy to it. Yeah, obviously you want to avoid these here, right? And then anyone with any pre-existing hepatic dysfunction, you probably want to avoid for those patients there, right? Maybe use a different antibiotic potentially. Again, for these drugs, they are renally eliminated, so you have to watch the renal function. Now, if it's a young, healthy patient that comes in with an upper respiratory tract infection, they're probably unlikely to have any issues with that. But if you have an older patient coming in from the nursing home, they may be more likely to have renal dysfunction at baseline. So you got to assess for that and then change your dosing accordingly. Now, how do you know how to change your dose based off renal function? You'll look it up, right? So you can go through UpToDate to go to your LexiComps, you can go to Facts and Comparisons, you can go to Hippocrates, lots of places, right? But you got to look it up. You have to know to at least look it up in the first place, though. So remember, these are renally eliminated, okay? Again, rash and diarrhea, fairly common with these ones, especially the diarrhea, just due to that disruption of the gut flora. So that's something you're going to be looking for, okay? As far as monitoring goes, you can look at renal, hepatic function, look at the platelets. If it's a short course, they're going to be on this for like 7 days, 10 days. Probably no further monitoring is going to be needed for those patients there, unless you suspect something's up. Okay. Now, how does resistance develop to the beta-lactams? Well, the bacteria figured out, well, if I deal with that beta-lactam ring, if I get rid of that, the drug is basically useless at that point. So we have something called a beta-lactamase that will come in and then destroy this ring here, and then your drug is no longer effective. So how do you think we combated that? Perfect. So we have a beta-lactamase inhibitor that will actually come in and keep that enzyme busy, so that way the actual beta-lactams can still do their thing, right? So this is where we're going to have our beta-lactamase inhibitors that are going to be incorporated with these drugs in order to make them more effective. What happens is when you put one of these on top of the normal penicillin, you're going to find that it gets a much broader spectrum of coverage and becomes much more used for a lot of different indications, as we're going to see there. The most common one you've probably heard of before is augmentin. Remember augmentin before? Quite possibly, right? So that's amoxicillin when you include it with clavulanic acid. Clavulanic acid will keep those beta-lactamases busy while amoxicillin goes and does this thing on the cell wall of the bacteria. Okay, so really just meant to overcome that resistance. The beta-lactamase inhibitor has no antibiotic activity on its own. You'll never see them by themselves. They're always going to be used in conjunction with the beta-lactamase or the beta-lactam antibiotic. So amoxicillin can be used by itself. Clavulanic will not be. They're always going to be used in conjunction. Okay. The other big ones you're going to see is going to be sulbactam That's going to be put with ampicillin to form unison. And then tazobactam is another one we're going to see in a few minutes and get incorporated with the drug piperacillin. And that's going to be Zosyn, if you ever heard of Zosyn before. It's a common hospital antibiotic you're going to see used pretty frequently. So what happens when we add a beta-lactamase inhibitor on top of an aminopenicillin? So we mentioned augmentin, we mentioned unison as being the two big ones in this category here. What do you notice about the anaerobic coverage? It's gotten a lot better, and you also notice that the gram-negative coverage has gotten better as well. So you're going to find that you're going to have increased activity against things like Bacteroides. Now gut infections potentially could be treated with some of these aminopenicillins plus the beta-lactamase inhibitor. And in fact, for things like skin and soft tissue infections, this can now be used occasionally. Diabetic foot infections. What type of bugs do you think would form in a diabetic foot infection? First off, why do you think diabetics are more likely to get infections? You got all that sugar. Bacteria love sugar. Chew on it. They replicate, right? Not only that, but also diabetics, what happens in their feet over time? They get neuropathy, so they can't feel things in their feet. So they don't know they have an infection. Maybe they step on a nail, or maybe they stub their toe and something happens, right? What happens in a foot when it's covered up by a sock and a shoe? What kind of bugs do you think like to grow in that environment? Anaerobes, right? Is there a lot of oxygen in your shoes right now? I can't really air up my feet right now. So again, it's a very anaerobic environment. But I have to think about that. So by using those drugs, now you can incorporate more anaerobic coverage by using the beta-lactamase inhibitor. Now it's good for that. This is also a very good one for animal and human bites, right? Remember we talked about the anaerobes that grow in the mouth and the normal skin flora that gets incorporated in those bites. This is usually good treatment for that. So if you ever hear someone like a cat bite or a dog bite, human bite, which does occur occasionally, especially if you're like Mike Tyson's in the state anytime. It's a very dated reference even for me. But yeah, so you can see that using the beta-lactamase inhibitor on top of that is going to get that good anaerobic coverage for those bites. Yes, ma'am.
If the inhibitor by itself that has no antibacterial activity, what makes it the penicillin have these effects with the anaerobic and negative now?
Yeah, so what increases the activity of the beta-lactam antibiotic just by adding on the beta-lactamase inhibitors? A lot of those bacteria that they now treat produce those beta-lactamases. So a lot of those bacteria, like those anaerobes, would be producing beta-lactamases that would render those drugs ineffective. If you think about why does mold produce penicillin? For protection. It kills off other bacteria so the mold can continue to grow. So this stuff has been around for millennia, right? It's been around since the Earth has been around. And so basically, I guess millions of years at that point, but it's been around for forever. So again, there's natural things that these bacteria produce that can neutralize that sort of thing, right? So in these cases here, by getting those beta-lactamases neutralized, getting them out of the way, now there's a lot more bacteria that those beta-lactam drugs can actually interact with and affect. If that makes sense. Okay. So next up, now we have our penicillinase-resistant penicillin. So there's another enzyme that actually can destroy just penicillin by itself, not necessarily the beta-lactam ring, but it can destroy the penicillins. And so we now call these the anti-staphylococcal penicillins. So in terms of coverage, what do you think happens? What do you get out of this? It covers staph now, right? So again, this is where methicillin used to fit in this category here is an anti-staphylococcal penicillin. What do you notice about its coverage? Very narrow spectrum, right? It only really gets some gram-positive coverage. Now, does this cover MRSA? No, right? Because again, methicillin-resistant Staph aureus is not going to be covered by any of these anti-staphylococcal penicillins. This is really good for MSSA. And in fact, this is what, if you have a patient who you're treating empirically with a very broad spectrum antibiotic and they grow back MSSA in those cultures, then this is what we narrow down to, right? So very rarely to use this as an empiric antibiotic. This is a really good de-escalation antibiotic if you have MSSA growing in those cultures there, okay? So the three that we use most commonly are nafcillin, oxacillin, and then dicloxacillin. Again, solely for MSSA purposes. And again, very similar side effects, monitoring parameters as you would see with any of the other penicillins we already talked about. But again, just know this has a very narrow feature here, or a very narrow spectrum. So if I were to ask you on a test question, say, you have a, say a some odd year old patient comes in and gets admitted for treatment for cellulitis, and the culture comes back, you're giving them vancomycin and whatever else, and they come back and they're growing MSSA. What drug would be most appropriate to de-escalate to? And I put penicillin VK, I put dicloxacillin, and I put, linezolid and something else. You would know by the time you get to that point that, okay, well, if it's MSSA, this is what I can scale down to using a dicloxacillin, oxacillin, or nafcillin, okay? These are kind of associations I want you to start making, especially when you're doing your studying, You're going through this stuff, like ask questions of your partners, kind of go back and forth and kind of come up with scenarios like this, because those are the kind of questions I'm going to ask on the test. Okay. And we'll have a Kahoot before the test, so that way at least you get to see kind of what my thought process is for some of these questions. So again, don't be totally freaked out at this point. Okay. All right. Okay, so looking at this now, we have the anti-pseudomonal penicillins. What do you think these cover? Pseudomonas, absolutely, right? So mainly, we used to have another one called ticarocillin, but honestly, you don't see it used too frequently. But what we do have is piperacillin, and then honestly, I've never actually seen piperacillin used by itself. I've only ever seen piperacillin plus tazobactam. And tazobactam, we said, is what? The beta-lactamase inhibitor, right? So it's used to broaden the coverage for piperacillin. So this has a really broad spectrum activity. So if you have a patient who comes in and they are, say, sick as snot, and they're going into the ICU, and you have no idea what you're covering, this is the drug they may use because it has such a broad spectrum of coverage. It's like, we don't know what it is. We're going to use something that's going to get everything, essentially. So you're going to notice here this has great anaerobic coverage, great gram-negative coverage, great gram-positive coverage. Notice, though, no MRSA, though, okay? It'll get MSSA, but no MRSA. So again, it's going to also cover Pseudomonas. So this is one of those things I want you to know. If a drug covers MRSA, or if it covers Pseudomonas, you should probably make note of that, okay? Good for empiric coverage of things. It's also good just to know if you have a patient that cultures back MRSA or Pseudomonas, you want to know what kind of drugs you can use to treat that. Okay, it's a small handful of drugs that will do those, but these are the things I want you to pick up on. Okay, so this is the anti-Pseudomonal. It's going to cover Pseudomonas. Very good if you have a polymicrobial infection. So I like to use this one quite frequently if I have someone who has maybe like, say like a patient with like Crohn's disease, right? Crohn's disease is what? Anyone know? It's autoimmune disease of the GI tract mainly, right? So you can have symptoms outside of it. The GI tract is a big one. They have so much inflammation. They have a perforated small intestine or large intestine, and they have all these bacteria getting into that interperitoneal space. Guess what? You can use something like a Zosyn because it's such good anaerobic, gram-negative, gram-positive coverage. It's going to cover all that stuff, right? So really good for intra-abdominal infections, gut infections. Zosyn is going to be a really good option for that sort of thing. But when I say polymicrobial, what am I referring to? Multiple types of bugs. Sometimes it's not just one bug causing the infection. It could be multiples. This is really good for that because it has such broad coverage there. This is really good for nosocomial infections, so infections that we have given to the patient in the healthcare setting, especially pneumonias, great for that. Intra-abdominal, as I mentioned, and anything pseudomonal this is going to cover. So again, this is a very broad spectrum. This is like using a bazooka versus like penicillins, like a little tiny, like, slingshot or something, right? So again, think about these in terms of how broad the coverage is, in terms of how much of the bacteria they're actually able to get there. Okay. Again, you can look at the dosing here just to kind of remind you, okay, it's every 6 hours. I know it's a time-dependent killer. I know based on the mechanism, same mechanism as all the other ones, inhibiting that cell wall, I know it's bactericidal, right? This is another big one you got to watch renal function for, okay? Now, in patients, they get a bacterial infection in the bloodstream. What do you think happens to their blood pressure when they start to get really infected, they get really inflamed? They get hypotensive, right? You see sepsis, patients are usually hypotensive. Now, what happens to, say, blood flow to places like the kidney? Does it go up or down? Think about it. When your body wants to perfuse, if it only had, say, 2 organs it could perfuse, where does it want to perfuse? The brain and the heart. Everything else kind of takes a back seat to that. So very frequently, you have these patients who are really, really sick, have, say, a bacteremia, developing sepsis. Their kidney function often takes a hit because their body's trying to maintain blood volume, it's trying to maintain blood pressure. The kidneys take a hit, and then so they can see renal toxicity. So when these patients are really sick, they're up in the ICU, you have to monitor the renal function because it's going to change over time. And so this is why you may start with a standard dose of Zosyn to begin with, but you have to go back and reassess, right? Maybe every day, maybe multiple times a day, go back and say, okay, what's the renal function doing now? And you may have to adjust the dose in order to account for that. Maybe instead of every 6 hours, you give it every 8, maybe every 12. To account for the fact they're not clearing as much of that drug, because you can see more of these toxicities that can develop. Okay, it's just something to keep in your mind. Okay, so those are the penicillins, right? Those are the main ones you're going to be using in your clinical practice. Up next, now we have our cephalosporins. So cephalosporins, very easy in terms of memorizing the mechanism of action. They still have the beta-lactam ring, so what do you think they do? They still inhibit the cell walls, and so they still are going to be bactericidal. Still going to cause that disruption there. So again, the mechanism is the exact same as the penicillins. Okay. The only thing that's really different is actually going to be these side chains here, right? Notice how the side chains are going to be different for these drugs here, which is why they get classified into a different group. Okay. They're also going to have different coverages in terms of the bacteria that they're going to be covering as well. Okay. So you can kind of keep the penicillins organized in your mind. Remember, you have your natural penicillins, aminopenicillins, anti-staphylococcal, You have beta-lactamase inhibitors, you had the anti-pseudomonal. Now we're going to bust into the cephalosporins, right? So different spectrums of activity based on categorizations here. So nice things about cephalosporins, they have really good CSF penetration. What do you think that's good for? Meningitis. If you think someone has meningitis, you're probably going to be using a cephalosporin, right? Because it has good penetration through there. It has good enough lipophilicity. It can cross the blood-brain barrier. It does not get effluxed out by any pumps. It just likes to stay there, which is good for those type of infections, okay? Now, when someone has a penicillin allergy, can they receive a cephalosporin? And if you work with old school providers, they'll say, no, can't do it, right? Anyone know why that is? And they think because they're similar in structure, right? So they look similar enough that maybe if you have a reaction to penicillin, you're going to cross-react and have a reaction to the cephalosporins. Well, guess what? People don't have an allergic reaction to the beta-lactam ring. It's all the side chain stuff they react to. So when you actually look at it, there's a very low risk of cross-reactivity between the two, okay? The reason why we used to think there's a lot of cross-reactivity is because back in the day, back before we had synthetic means of forming these drugs, we actually used to use the mold to produce each of them, right? So certain types of mold that will produce cephalosporins and certain types will produce penicillins. Well, we get cross-contamination there. So back in the day, you get penicillin that had some cephalosporin in it and vice versa. So when you cross-react it, it's because you're probably getting some penicillin mixed in there. Nowadays, we have a very pure drug that we're using here. There's very low cross-reactivity. So if you have someone who has a true anaphylactic allergy to a penicillin, there's less than a 1% chance they're going to cross-react with a cephalosporin, okay? And so I have to tell that providers, I have to have the argument with them on not a routine, it's getting less nowadays, but sometimes I'll have like an old school provider who's moonlighting in the ER, and they'll say, oh, they have a penicillin allergy, I can't use a cephalosporin. I said, well, go ahead and do it. And they're like, well, what if they have anaphylaxis? I said, they're in the ER. It's the best place to have anaphylaxis, right? You treat them right away. And sure enough, they'll give them a test dose, see how they do, and if they don't have a reaction, send them home with a prescription, right? That's a perfectly valid thing to do. If you think there's a low risk for them having a reaction, give them a test dose, monitor them, see how they do, and then you can go from there. Okay, so very low chance. And because the issue is if you tell me, okay, well, they can't receive penicillins, and now they can't receive cephalosporins, that's going to be dozens of drugs they can't receive now. And what if they get an infection later on? They may need treatment for it. That is going to be very difficult to manage in those patients there. So very frequently, if you have someone who says, oh, I can't receive cephalosporins, look in their past. They may have received one before, and that way if they received it before and they had no problems, they're probably not going to have an issue this time as well. Okay, so something to think about. Again, monitoring is going to be very similar with the penicillins, right? So you're going to be looking for things like signs and symptoms of allergic reactions. You're looking for things like nausea, vomiting, diarrhea, very common for these cases here. Now, what's interesting about the cephalosporins is that their spectrum of activity is based on the generation of cephalosporin you're dealing with. We're talking about 5 main generations of cephalosporins, okay? You think, oh, wow, I already learned all these classes of penicillins, and I got 5 more classes of cephalosporins. Again, this is probably the biggest group that we're dealing with, just because, again, there's a lot of cell wall active drugs here. Now, some things to note, in terms of anti-pseudomonal activity, these are the 4 that are going to have activity against that: ceftazidime, cefepime, ceftaroline, and ceftolozane. Now, what do you notice about the naming conventions? If it starts with a ceph, either a CEPH or a CEF, chances are it's cephalosporin, okay? Some drug classes are really nice and they have that naming convention. Like, how do you tell a penicillin? A penicillin at the end of it, right? So again, it's very easy to tell it's a penicillin. Fantastic, that's great. Not every class is going to be quite that easy, right? So again, try to find those naming conventions where you can to make it easy to memorize those as being in that bucket of cephalosporins, but don't always rely on that. This is just one of those cases where it's useful for that. And again, most of these, and I'll make one notable exception, are going to be renally eliminated, so you have to watch for the renal function. You have to adjust how often you're giving these drugs based on the fact that they are renally eliminated. So, in general, this is a good graph to remember for your cephalosporins. As one moves up in cephalosporin generation, the more gram-negative activity you get. So, this yellow line is gram-negative activity. As you go from first to second to third to fourth, you get better gram-negative coverage. You get pretty good gram-positive coverage in your first generation of cephalosporins, but you actually notice it goes down as you go further up in generation, and then it kind of picks back up in the 4th generation. So, in general, higher the generation of cephalosporin, the better gram-negative coverage. Lower the generation of cephalosporin, the better gram-positive coverage you're going to get, okay? We'll note the exceptions as well, because there's always exceptions with everything. So starting with our first generation cephalosporins, does anyone think they're going to go into surgery? Have the inkling you might? If you think you might, you're going to get used to cefazolin. It's actually one of the most common ones you're going to use in the surgical setting here. This is great for surgical prophylaxis. Probably 95% of your patients are going to get a dose of this right before surgery. Now, why do we do surgical prophylaxis? Because if you're cutting into somebody, you can introduce them to that skin flora. So even though you do your best to try to disinfect a patient beforehand using a betadine and stuff like that, there's still a risk bacteria could get in there when the bellies open up or the hearts open up, whatever the case may be, chest open up. So you always want to use surgical prophylaxis for these cases. Even for laparoscopic stuff, you're still going to use surgical prophylaxis. So basically what we'll do is we'll give a dose of cefazolin 1 hour prior to surgery, and then we get concentrations nice and high so that any bacteria that may find their way inside of that wound, guess what? They're going to get killed off by that ANSEF. And so we do that for our patients in order to help prevent post-surgical infections, which is a major complication of surgery. You want to make sure you try to prevent that if ever you can. So the reason why we do that, though, is again because that's good coverage against skin floras, right? So things like MSSA, it's going to have good coverage against that. It's not going to cover MRSA. So again, make note of that. No MRSA coverage with these first-generation cephalosporins. But it does have good coverage against normal skin flora. Okay. Also really good for like UTIs, kind of basic UTIs that are not resistant to much else. Really good for that. Notice here there's no anaerobic coverage though. Okay. No anaerobes, pretty okay gram-negative coverage, pretty decent gram-positive coverage for your first generations here. So cefazolin, cephalexin, which is Keflex, is a very common oral antibiotic you might see used out there. It's actually probably one of the free antibiotics you might find like at Publix or somewhere like that. Again, these are the two main ones you're going to use out of this category here. Okay. Yes, ma'am.
So when you're giving this as a prophylactic treatment, would you? Oh wait, never mind. I read it wrong. Sorry.
Fantastic. I like the questions I don't even have to answer.
Yeah.
Yep, it's good. It's okay, no worries. So again, it says good gram-positive coverage against one notable hole for the cephalosporins is that none of them cover enterococcus. So you don't frequently see these being used for gut infections because it doesn't really cover the enterococcus. This is where something like a piperacillin tazobactam might actually have better coverage in those cases there. Okay. So in general, no gut coverage, but for good surgical prophylaxis, basic UTIs, things like that, this is a really good class for that. Okay. Again, it'll cover some basic E. coli and proteus and things like that, but once it gets much more kind of complicated than that, then these are not going to be sufficient for most of those UTIs. Okay, second generation, it's going to include things like cefotetan. You're going to have cefoxitin, cefuroxime, and then cefprozil. Again, notice they're going to have better gram-negative coverage than your first generations, maybe a slightly less gram-positive coverage here. This is good for a lot of like things like H. flu. You're going to get things like Neisseria, Proteus. You can still use this for UTIs. You can get away with using this for upper respiratory tract infections. We'll cover those bugs. And again, I mentioned this not to have you memorize every single indication for these drugs. We're going to cover those later on when we actually talk about specific disease stage, right? So when I get into the ENT section, we'll cover otitis media. But again, I want to at least give you some coverage here. I at least want to give you some ideas about where you might be seeing these used most frequently. Okay? Make sense? Sometimes it's used for surgical prophylaxis, but not too frequently. I might see this being used more for like a patient with like appendicitis who's about to go to surgery. So when I think appendicitis, what are you thinking? What kind of bugs might you think might be there? Gram negatives and anaerobes, right? So I might use something like a cefoxitin, has a little bit better anaerobic coverage, better gram-negative coverage than, say, something like an ANSEF because of the fact that I can hopefully, if anything gets out from that appendix, spills into the intra-abdominal space, I can try to go ahead and get that eradicated with that prophylactic antibiotic. So sometimes it's very surgery-dependent when you might use one drug versus another, okay? Okay, next we have our third-generation cephalosporin. So now we have this workhorse, ceftriaxone. This is probably the most common one you're going to give in the hospital setting because it has good broad coverage here. No, no MRSA coverage, but it gets a lot of good strep coverage. You're going to see that it covers a ton of gram negatives, but no anaerobic coverage here. Okay, so good gram negative, good gram positive coverage. Ceftriaxone is a workhorse. It gets used for pretty much everything, right? Especially if a patient comes into the ER and they can't tolerate oral antibiotics, we might give them a shot of ceftriaxone potentially, right? One thing to note with this is that you cannot use this in the first 30 days of life. Okay, there's actually a reaction where it will compete for the same binding sites as bilirubin in the neonatal period, and we can actually induce jaundice in these kids here. So during the first month of life, we don't give ceftriaxone. As an alternative, we can actually give cefotaxime, right? So this is really good for neonatal fever and sepsis. And again, one of the big things you're worried about with a neonate who shows up with a fever is you worry about meningitis. And we said that cephalosporins, are they good for meningitis? Yep, they absolutely are. So actually, this is one of the cornerstones of therapy for those kids there. We'll give them a cefotaxime if they show up in that first 28 days of life. We'll go ahead and give them this if we're worried about neonatal fever and sepsis, right? Ceftazidime, this one is not used too frequently clinically. It does have good pseudomonal coverage, but it gets resistant really quick to that. So we don't use it very frequently. Really the two big ones you want to keep in mind, actually the three big ones, are ceftriaxone, cefotaxime, and then ceftonir is a good oral third generation cephalosporin. So cefixime can also be used occasionally, but ceftonir, ceftriaxone, these are probably the two most common ones you're going to run across in your clinical setting. As I mentioned, loses a little bit more gram-positive coverage, but has really good gram-negative. It has extra coverage against things like monoxide catarrhalis, serratia, so again, good for some of those upper respiratory tract infections. Now, I mentioned there's one notable exception to the fact that most of these are renally eliminated, and this is going to be ceftriaxone. This one's really nice because it's easy to dose. It doesn't matter how bad the patient's renal function is, guess what? It's the same dose regardless because it is hepatically eliminated, okay? So because this one does not go through the kidneys, I don't have to worry about renal dose adjustments. And again, people tend to go with the easy things in life, right? Avoid adversity, avoid having to look up what the renal dosing adjustment is for something like cefotaxime. Instead, I have to go Rocephin, easy. Also, one of the interesting things about Rocephin is that ceftriaxone, you only have to give it one time a day in most cases. It has a long enough half-life that even though it is a time-dependent antibiotic, it has a long enough half-life that it stays above that MIC for 24 hours. Okay. For some more severe infections, things like meningitis, I might give it Q12 because I want to get the levels higher because I want to drive that drug up into the CNS. But for the most part, Q24-hour dosing is going to be most frequent. Okay. So again, this is one of those exceptions where it's still time dependent, but Q24-hour dosing is appropriate. Okay. Okay, next up we have our fourth generation cephalosporins. The main one here we're going to cover is going to be cefepime. This one is a good broad spectrum antibiotic, has good pseudomonal coverage and great gram-negative coverage here. I kind of think about Zosyn, which is piperacillin tazobactam, and cefepime kind of in the same category as one another, with the one notable difference that Zosyn has anaerobic coverage, cefepime does not. So if I have a case where I'm worried about gram-negatives, but I'm not really worried about anaerobes, cefepime is a really good option for those cases there. If I am worried about anaerobes, like an intra-abdominal infection, Zosyn might be a better option for them. But really, cefepime has a good place. We use this a lot for patients with febrile neutropenia. Anyone know when you might develop that? Yeah, in cancer. So if we were like, if you have a patient who's on active treatment for cancer, let's say for leukemia, we have a lot of leukemia in children, we're giving them chemotherapy to eradicate a lot of those white cells. What's their ability to fight off infection? It's kind of zero at that point to a certain degree. And so they will present, oftentimes the only thing they'll manifest when they have an infection is fever. So they have febrile neutropenia. We'll give them cefepime because it has good broad coverage. It'll get most of the stuff they might be infected with most likely. So again, that's another indication here. We use prophylactic, or not in prophylactic, but they're empiric antibiotics in order to cover a wide range of things until you get a culture back and you know what it is. Does anyone know when you should get a culture in terms of starting antibiotic therapy? Before or after I start antibiotics? Why before? Because as soon as the drug's in the system, it might start to interfere and prevent those bacteria from growing, right? So you may even you may have a legit infection, but if you give antibiotics first and then get the culture, they may not show anything, may not grow anything back, and you think, okay, well, my antibiotics aren't treating anything, maybe it's something else, when really it was that bacteria in the first place. So always get your cultures first and then give them the antibiotics, okay? Now, sometimes you may have the best intentions in the world and say, okay, I'm going to do that, but what if you had like a junior nurse, didn't know any better, she's looking at her orders and says, okay, let me go and give the antibiotic first, that's easy, and then I'll get the culture. That's a problem, right? So you need to know the timing of those things to make sure you can interpret those labs and those cultures when they come back, okay? Now, we have these fifth generation cephalosporins. These ones are used exceedingly rarely. So again, you know, how often do you think we come out with a brand new antibiotic? You think it's like super frequent or very infrequent? It's very infrequent, right? So again, this is one of those things where it's not like a blockbuster. Like it's not like, you know, hypertension, like gazillions of people have hypertension, a gazillion people have diabetes. It's much more profitable for drug companies to make something that can be treated in a ton of patients than something that's relatively rare in comparison. So we really don't have as much research that goes into developing new antibiotics, and so it's relatively rare when we get a new one that comes out. As such, they're also more expensive when they first come out, and we like to hold on to them. So we're kind of like Gollum with the One Ring. You know, we're just like, oh, this is my precious. You cannot have this antibiotic. I don't want you to use it because I don't want it to get resistant, right? And so we will oftentimes hold off on using this until it's absolutely necessary. We have a really good clinical indication for it. So this first one we have is ceftaroline or Teflaro. This is going to have great gram-negative coverage. It'll cover gram-positive. Again, notice no cephalosporin is going to cover enterococcus. That's kind of a class sort of effect here. But this is interesting. This is the first drug we found now that will actually treat MRSA. Actually, the first drug, one of the very few drugs that covers MRSA and Pseudomonas. Very rare they're going to find that in one drug here, and this is one of those cases. There's no anaerobic activity, but potentially if you had someone who had a co-infection of MRSA and Pseudomonas, this might be a good drug for that patient. But again, we like to hold off on this sort of thing, try to maintain as much susceptibility as we can for as long as possible. Okay. As I mentioned, this is again for good, like community-acquired pneumonias, skin and soft tissue infections. Now, these are just the approved indications. Does that mean I can only use it for these two indications? No, you can go off-label, right? It's certainly okay if there is clinical data to back that up, but that's just something that every drug is going to have indications that it's approved for, although there's a lot of stuff you're going to use it that's off-label potentially. Okay. And then the last cephalosporin here is going to be this one called ceftolozane in combination with the tazobactam. And we said tazobactam is what? Beta-lactamase inhibitor, right? So again, this is combining a beta-lactamase inhibitor with a cephalosporin. Again, this is the first drug that did that outside of the penicillins here. And again, this is nice because it has really good activity against gram-positives, has good anti-pseudomonal coverage, and it has good anaerobic activity. So you can see here by adding that beta-lactamase inhibitor on board, that increased the anaerobic activity of it. This is another one we're going to hold off and try not to use as long as we can, unless they have a really good indication to use it in those cases there, right? So oftentimes you may be in the hospital, and say for instance, you're working in the ER, you have a patient that comes in, you're like, okay, well I'm going to go ahead and use this crazy antibiotic. It's like super expensive, and we've only used it once in the past 5 years. You may get pharmacy calling down and saying, like, you can't use that. You might be saying, what? I'm the provider. I can do what I want, right? Oftentimes, no, right? This is part of that kind of collegial sort of spirit we have here, where we try to talk you back off the ledge of using some of these antibiotics here. And oftentimes we have things like antimicrobial stewardship programs. They're in place that says that, hey, you can't really use this unless you have approval by, say, like infectious disease. You need to make sure you not use this unless you failed therapy with something else. So sometimes there's restrictions in place to prevent you from using some of these kind of more specialized antibiotics versus like Rocephin. You can give Rocephin to whoever you want. No one's going to stop you, right? So again, there's certain drugs we try to be a little bit more protective of just because once they get resistant to that, then we don't really have any other options. Okay, next we have the monobactams. Luckily, there's only one monobactam that's out there. It's called aztreonam or azactam. Now, if you notice, this is still a beta-lactam drug because what do you notice here? Beta-lactam ring, right? Against the side chains that delineate it from being a cephalosporin or a penicillin, right? This one has very narrow coverage. It covers a ton of gram-negatives. It'll cover Pseudomonas, but no anaerobic coverage, no gram-positive coverage. So very kind of narrow in use here. The only reason why we would use it is because it used to have, back in the day before people thought you could safely give penicillin or cephalosporins to a penicillin allergic patient, this had no cross-reactivity whatsoever. That's kind of what its big marketing push was. Nowadays, we realize that it's not really that necessary to worry about the cephalosporin cross-reactivity. So this doesn't get used too frequently, but this is another one that covers Pseudomonas, so it's good to note it for that, right? Again, it's going to be renally dose adjusted, so you have to watch out for that. Again, very similar monitoring and side effects as you would see with the penicillins, right? Again, no cross-reactivity with beta-lactams. So if you had someone who had a really true type 1 allergy with penicillin, you could definitely give this with them. There's no cross-reactivity whatsoever. And again, it's not that beta-lactam ring they're reacting to, it's all the side chain stuff they're reacting to. Okay, next we have our carbapenems. So we have imipenem, meropenem, ertapenem, and then doripenem. So again, you can tell a carbapenem because that's penem at the end of the name, right? These are like the nuclear bombs. I call these gorillacillin. They're extremely good at what they do, and they do it with very little discretion. They have such good coverage. They cover basically everything except for MRSA. Okay, these are really good to use if you have patients who have resistance to things like cefepime. If they have resistance to things like zosyn, this is what you go to after that, essentially. Very broad coverage, and because of that, they tend to get overused. You're going to find because they do cover everything, right? So good anaerobic coverage, good gram-negative, good gram-positive. The only thing it doesn't cover is MRSA, basically, right? And again, the reason why we worry about these is because when you start to have drugs that are developing multi-drug resistant mechanisms, you start to lose activity of cephalosporins, you lose penicillins. This is the thing you have to jump to, right? If you have patients who are producing what they call extended spectrum beta-lactamases, guess what those do? They make those beta-lactamase inhibitors ineffective at that point, right? So you could have a piperacillin tazobactam that is basically neutralized because it develops ESBL. So if you ever see ESBL, that's what the carbapenems are really made for, is to cover, to overcome that hump there, right? So good for meningitis, good for nosocomial infections. But this is another one we really like to reserve and hold off on using if ever possible, right? This is one of those things where at our hospital, you have to have approval from infectious disease. Like you actually have to have the doc call us up and say, hey, this patient is allowed to get this, right? That way you have a little bit more oversight and make sure you're not overusing it. Only thing to really note with this is that you do need to be careful for seizures if you have patients who have renal dysfunction and they're on imipenem. Okay, that's one notable thing here is if you have a patient with poor renal function, they can't clear imipenem, they're going to hold on to too much of it and they can develop seizures from that. So that's one unique thing you'll see with imipenem that you don't really see much in the other agents there. Okay. All right, I have about 5-ish minutes left. Oh, yes, ma'am.
Sorry. So, for instance, you had said like if you at first you want to do a broad spectrum and then bring it down to a narrow spectrum, would you still run the risk of creating resistance if you killed off those bacteria initially and then you do switch?
Yes, but less likely than if you were to continue that broad spectrum antibiotic long term, right? So if I were to say, say a culture comes back in say 3 to 5 days or so, and it comes back positive for say MSSA, right? If I kept using something like vancomycin for the long term, I'm more likely to develop more resistant bugs than if I were to then downscale it. So again, sometimes you have to go broad in order to try to get, because again, you're working off your best guess, right? Because if you don't have a culture there present, because it takes too much time, you got to treat that patient right now. You need to use something, right? So again, you're going off your best guess. That's why you're going off guidelines. If you have someone who you think has meningitis and you think is bacterial, these are the drugs you want to use because that is most likely to get your stuff, the bugs you're covering there. Then you can de-escalate based off of what actually grows back. Any other questions? I think I'm going to check the board, see what's going on there. Hopefully someone has some good questions there. Oh, I got 2 already. Let's see. Okay, if a patient claims to be allergic to medication, but you doubt their reliability, how do you proceed with prescribing the proper drug? It's a good question. Anyone have any answers? I would like to know that as well. No, just kidding. It's about having a conversation, right? So say, for instance, I had a patient who was adamant that said, oh, I have a penicillin allergy. I cannot receive penicillins. I can't receive cephalosporins, right? You, being the astute clinician, would know that, hey, I know there's a less than 1% cross-reactivity. If I know they had maybe some rash with, say, amoxicillin they had 15 years ago, and I want to give them ceftriaxone now, I know there's less than 1% reaction, they're going to have any issues, right? You have to have that conversation with the patient. Be like, listen, I think that this is the right thing for you. I think this because, 1, this is the type of infection I believe you have. I believe this is the right drug for that. I also believe there's a very low risk you're going to have a reaction to this medication here based off of X, Y, and Z. Okay? And again, you have to tailor it to their education level. You have to tailor it to kind of what they are. And ultimately, if they say, no, I don't want that, what do? You got to find something else, right? Again, it's about a partnership with your patient. Sometimes they're not going to be super agreeable with you. It's not like you can just strap them down against their will and give them ceftriaxone, right? And then see, I told you we weren't going to react. Press-Ganey scores are not going to be great from that, right? So it's one of those things where I have to have a conversation. But again, the more intelligent you are about how you or how eloquent you are in illustrating your points to your patients, or how you sell it, is going to be able to get them on board with you most likely. Okay. Let's see. Just to confirm, beta-lactam is a competitive inhibitor against the 2-D-alanines for the PBP enzyme. That is correct. Yes. So because it looks like those 2-D-alanines, that penicillin binding protein can't tell the difference, and so it'll just basically bind to it instead of those 2-D-alanines. So you can't make that cross-link there. It's still referred to as penicillin binding protein when it's not in the presence of a beta-lactam drug. Yes, because we identified that protein based off its activity when it reacted with the beta-lactams and penicillin. That's basically how we identify it. So it's always the name there. Okay, any other questions? We're going to feel you need some time to decompress a little bit. Get ready for Thursday, EpiBio. It's going to be great. I'll see you guys then.